take a 2-second pause, and after that you can begin. Okay.
Okay.
Yeah, sir, we are live.
So good afternoon, everybody. Myself, Dr. Kundan Ingale. I welcome all of you for this webinar organized by Indian Society of Assisted Reproduction, ISAR, along with Zydus, along with Dr. So today my job to talk to you about optimizing IVF success rates. So, optimizing results means what exactly? So, the definition of optimum is the best that is possible. It means, suppose there are certain strategies for the one particular treatment, then I think what best we can do to yield a maximum results, and that is what is optimization, or a condition that is most conducive to a function. So, we have to discuss about many other conditions which can help us to get a maximum success rate when it comes to ART or IVF treatment. Now, when it comes to natural conception and IVF, it is like we are trying to mimic a natural conception where naturally there is a follicular development, we do that. Then the follicle rupture endogenously inside. Here we aspirate the oocytes outside the body. Then there is a oocyte pickup where we do it that part in a lab. Then transportation of the sperms where that is done by a ICSI. Then it is a fertilization where the sperm is penetrating the oocyte, which is done by an intracytoplasmic sperm injection by micromanipulation. And then there is an embryo formation, which is here done in an incubator with the embryo culture. Then transport of the embryo, where in IVF we do embryo transfer. And the most rate limiting step is implantation, where the embryo implants into the endometrium. And that is something which is very important step when it comes to IVF. So these 7 steps or 7 processes out of 8, which are under our control. Now, what we need to do, that we have to be sure that these 7 prior steps are happening properly. Now, the only one place or a process where we cannot play any major role, which is comes to implantation. And I think that is why we have to see a lot of different strategies to find out that how can we improve this implantation. Now, it is defined as migration, attachment, penetration, invasion of embryo into the endometrium. All these 4 processes are important, and once they happen, we get a beta HCG positive. It's a success limiting step in IVF, of course, because that is something which we are looking at and waiting for beta HCG day that yes, it has happened naturally. Now, for a successful implantation, we need at least 3 important factors. One is a receptive endometrium. We need a very good quality blastocyst embryo, and also some kind of complex sequence of signaling events that are crucial in synchronizing a dialogue between a maternal tissue as well as the embryonic tissue, which will actually mediate this process of implantation. When it comes to optimization of success rate of IVF, I think my talk is going to summarize on these particular points. Selection of patient, it starts from the age of the patient. Then there are certain adjuvants which we will be discussing today, which we can prescribe before IVF to improve the gamete quality. Then comes the embryo quality. We know that embryo quality depends on oocyte as well as a sperm quality. So we'll discuss about different strategies about improving the oocyte quality and the sperm quality. Also, we will discuss about optimum embryo culture system. So what should be ideal day of transfer and what quality of embryo we are looking at. Then endometrium factor, where we'll discuss about endometrial thickness, blood flow, and receptivity, how to improve it. And of course, we are going to discuss about fresh versus frozen embryo transfer benefits and the disadvantages. We'll start with the selection of the patient, that is age of the patient. We know that the influence of age on the oocyte euploidy rate. Remember, in this paper by Dr. Fisher, he has clearly demonstrated that the percentage of euploid oocytes will significantly decrease as the woman progresses beyond 35 age. And it continuously, if you look at this graph, it continuously declines and it never steadies down. So I think when we discuss about IVF success rate with our patients, I think we need to keep it in mind if there are patients who are from elderly group that is more than 35 age, we must counsel them about having a less number of oocytes, having a probably a bad quality oocytes, and it's really gonna impact on the embryo quality. Coming to age-related decline in blastocyst, that is euploidy rate. Now, this was again by Dr. Steve. He has also demarcated that if you look at this line here, that after 35 age, there is a significant decline in the blastocyst formation, which are euploid status. And all this related because the aging which actually affects the mitochondrial function, it impairs it, which actually a source of energy. Not only that, there is a granulosa cell apoptosis which is significantly increased after this age, which ultimately affects the quality of the cell. Also, there is a significant increase in the oxidative stress with this kind of oocytes, which also affects the quality. So age is very, very important when the success rate below 35 age and beyond 35 age will vary. And I think that is very, very important prognostic factor we need to discuss before. Coming to embryo quality, where again, let's discuss about the strategies after the selection, that is oocyte quality, how to improve it. Now, we know that in a hyper-responder group, polycystic ovarian syndrome is the most common group we come across. And in these particular PCOS patients, the obesity is one factor which really affects the oocyte quality, and prior weight loss before commencing the ART treatment is the most important strategy to be followed, which will ultimately help us to reduce pregnancy, which actually this particular obesity reduces the pregnancy rate. It also reduces the response of ovarian tissue to the gonadotropins. We get less number of oocytes in these patients. We have a higher miscarriage rates in comparison with the thin patients. So whenever we are dealing with obese PCO patient, weight reduction, at least 10% from the present weight will have a significant impact on the oocyte quality. Also, at the same time, that we must measure serum TSH and the prolactin, that is thyroid and prolactin status, prior to commencing the ART cycles. And if they are abnormal, correct it, get it into the normal so that we get a perfect, adequate ovarian response. Then ovulation induction protocols for hyper responders, normal responders, and poor responders. So we have to individualize our ovulation induction protocols. Maybe it's in whether should we give it GnRH agonist or versus GnRH antagonist. And I think by evidence, it has been clearly said that when it comes to IVF in all three responders, GnRH antagonist is the most safest protocol to be followed in when it comes to ovulation induction protocol in ART. So these are a few strategies. Now, nutritional supplement plays a very, very important role. Now, this was a study in 2015 that they studied that if the patient has a serum folic acid levels beyond 26.3 nanogram per ml, or serum vitamin B12 more than 701 picogram per ml, then it is associated with a higher probability of live birth in comparison with the woman with these concentration less than or equal to the median. So I think supplementing these vitamins prior to commencing the treatment for at least minimum 2 to 3 cycles is going to impact a live birth rate of the result, and that is why I see to it that they maintain these levels into this range. Again, a very important part of the drug regime before starting ART is an antioxidant supplementation to a woman, especially who are little on the elderly side, because micronutrients before IVF cycle, they protect follicular fluid and serum proteins, and they protect them from the damage which is happening from the oxidative stress. It has been seen that mean number of good quality oocytes, they are significantly increased when you have given antioxidants minimum for 2 to 3 months prior to the ovarian stimulation. Then it has resulted into a very good quality oocytes. Not only that, even in numbers, that is in qualitative as well as quantitative characteristic of the oocyte. Next line drug is a testosterone gel, that is androgen supplementation to the patients who have been selected as a poor responders. So this single blinded randomized clinical trial has demonstrated that there is a significant increase in the number of oocytes, number of embryos also the pregnancy rate and a good quality embryo rate in a group 1, that is patients who receive testosterone gel. So testosterone gel supplementation has a significant impact on the fertility rate, especially in women with a poor response in IVF cycles. And of course, we are expecting a large sample size studies in future. The meta-analysis regarding the same discussion has revealed that women who has received transdermal testosterone prior to IVF or ICSI cycle had a twofold increase in the live birth rate. They have also a twofold increase in the clinical pregnancy rate, and also significantly more oocytes have been retrieved when they have been supplemented with a transdermal testosterone gel. These results should be interpreted with cautions due to small sample size of the studies used and the heterogeneity. As I said, in future we are looking for some large size studies, but till now whatever evidence we have, it is clearly shows that supplementing testosterone transdermal gel instead of DHA plays a very important role in increasing the reproductive outcome after IVF. There is another very important group which is hyper-responder or polycystic ovarian syndrome patients, especially obese category. The metformin or minoxidil, those are insulin sensitizers. So in this crossover randomized control study of 34 PCOS obese women, they demonstrated that metformin and minoxidil significantly reduces the insulin response to GTT and impaired insulin sensitivity. Especially metformin, they significantly decrease the body weight and they improve the menstrual pattern as well as the Ferman-Galway score. Metformin also associated with a significant decrease in LH and estradiol levels, as well as along with that androgens and AMH levels. So it has shown that both of the drugs, they plays a very important role, but among them metformin especially has been shown and given a significantly high level of free sex hormone groups in the follicular fluid, especially in the PCOS woman, indicating a decrease in the oxidative stress level. And they have seen that a higher number of good quality M2 sites were observed in a patient who's received DCI or metformin, which is in favor of giving these insulin sensitizers prior to the treatment for minimum 70 to 80 days prior to the ovarian stimulation. Now, all the accumulation of the evidence says that both isoforms of inositol, that is minoxidil and dichlorominoxidil, they are effective in improving ovarian function. Though specifically, if we discuss, minoxidil shows the marked effect on the metabolic profile of these patients, and dichlorominoxidil, they reduce the hypoandrogenism much better than minoxidil. So giving a combination of these kind of insulin sensitizers are worth strategy to improve or maximize our success rate so that we get a good oocyte quality. Coming to the next gamete, which is a sperm factor. Now we know that sperm DNA fragmentation is one of the very common problem which is affecting the sperm quality and ultimately the embryo quality. In this systematic review and meta-analysis, that significantly higher live birth was noted after IVF in men with a low sperm DNA fragmentation compared with those with a higher sperm DNA fragmentation. As you can see it is more favors or higher pregnancy rate in a low DNA fragmentation index. So are there strategies which will help us to reduce this DNA fragmentation in couples undergoing ICSI? So a study by Steve in 2016, he has demonstrated that these are the strategies which are going to be very effective by evidence, by literature evidence. Whenever we come across abnormal sperm DNA fragmentation, that is higher DFI, then look for some confounding factors like smoking and obesity. Avoiding these factors, they will promote, these factors which promote oxidative stress. If they stop it, then after 3 months, there is been seen that there is an improvement into the gamete quality or the sperm quality. Also, the oral antioxidant intake, which has been proven now, we have a lot of evidence that it proves that if we supplement these antioxidants like vitamin C, vitamin E, folic acid, selenium, zinc, and L-carnitine, most important antioxidant combination, if we supply to these particular husbands having a higher DFI, then we see that they really show a good improvement into the sperm quality. Treatment of underlying pathology, like if there is a grade 3 varicocele has been found to be associated with a higher DFI. So doing a repair of grade 3 varicocele has shown a significant improvement into the DNA fragmentation in status. Also look for genital tract infections and leukocytospermia in semen analysis and treat it before doing IVF, which will help us to reduce the oxidative stress in the reproductive tract. Applying the ART technique for such couples having a higher DFI also plays one of the strategies, like especially when we discuss about ICSI. It has been seen that the percentage of good quality embryos are more better found when ICSI was done instead of a conventional IVF. So ICSI itself probably bifurcate or completely bypass the impact of higher DFI. So one of the strategy can be doing ICSI even if it is a sperm count and sperm motility is normal. So instead of doing conventional IVF, ICSI will be a more better strategy. Now, while doing ICSI, the source of sperms will be a very important important part. And there you can tell the patient to have a short ejaculatory abstinence. So maybe he ejaculates quite frequently in the recent last 2 weeks, and then probably just 2 or 3 days abstinence will be sufficient enough to get a good sperm count, because the more they stay in the reproductive tract, the more they will get exposed to radical oxygen species, and then they have a higher DNA fragmentation index. If we do not take a ejaculated sperm for ICSI and we extract the sperm from testicular biopsy, I think that is something which we will discuss in the future slides, is one of the very important strategy in this group of patients. Also, the sperm selection techniques, like there are magnetic cell sorting, then physiological ICSI and IMSI. We will discuss the evidence, what it says. Now, there is one more important factor, which is abnormal vaginal microbiota may be associated with poor reproductive outcomes, a prospective study in IVF patients. Now, in this particular prospective study done in 2016, which says that if a patient has a normal vaginal microbiota, then the pregnancy, that is positive pregnancy rate, as well as the clinical pregnancy rate, they are significantly higher when there is a normal vaginal microbiota is seen, and it is significantly lower if there is an abnormal vaginal microbiota. Now, they have concluded that if there is abnormal vaginal microbiota, it is always associated with a poor reproductive outcome. So that was the evidence where we started thinking that if we supplement these patients with a lactobacillus prior to commencing the treatment, probably it will help us to have a normal microbiota, which will ultimately improve the reproductive outcomes. Not only that, they demonstrated that in this another study in 2016, that live birth rate per transfer was almost 58% in patient who has got a lactobacillus units, and it was significantly low, that was only 6.7% in a non-lactobacillus community. So we need to understand that presence of non-lactobacillus microbiota, even if it is a receptive endometrium, is associated with a significant decrease in the implantation, pregnancy, ongoing pregnancy, and live birth rate. So we have not many papers which are coming up now in recently last 2 years about supplementation of microbiota, which will help to have a good colony of these bacteria in endometrium as well as in vagina. Coming to our that same discussion about antioxidants for male infertility, this was a Cochrane review in 2011, which clearly said that there is an increase in the live birth rate and pregnancy rate when these antioxidant molecules are given in combination. They also said that they are not harmful, and it has to be better that if we give them in a combination state, and there is a substantial improvement into the sperm quality. Now, other sperm selection techniques, can they really help whenever we come across a higher DNA fragmentation index? So this is one of the technique which is very favorite of our embryologists, which is a microfluidic chip technique in sperm selection, especially in ICSI for unexplained infertility. Now here, what they found that in a group 1, where 61 patients, they were treated with conventional CMUP technique, those were controls, and another group where 61 patients with a microfluidic technique was used for a sperm selection. So they realized clinical pregnancy rate and a live birth rate and fertilization rate, they were not significant. They were comparable in any of these technique or in both the groups. But total number of grade 1 embryos and also after the transfer, surplus number of grade 1 embryos, they were significantly more into the group where a microfluidic technique was used. So somewhere that particular technique probably help us to select a good sperm, which ultimately gives us a good number of embryos, so that not only that we have a good grade 1 embryo for a transfer, but also we have another backup grade 1 embryos, maybe for the future fertility or in case of failure to repeat the cycle. So I think uh, though it is a very less evidence we have, but it's a prospective randomized control trial. But here it gives us some evidence that yes, it can be a good strategy. Sperm selection by prior hyaluronan binding, that is physiological ICSI. I think this particular study, which is been studies where PIXI versus ICSI, and that was a phase 3 trial done on 2,772 couples underwent. They were randomized, and 2,752 couples were included into this primary analysis. What they realized that after a group which received a PIXI or which underwent PIXI technique, the live birth rate and clinical pregnancy rate, they were not significantly different when it was compared with the ICSI. But they realized there is a significant difference in the miscarriage rate, which was lower in patient who received PIXI, that is hyaluronized binding selection method. So PIXI offered no clear advantage when it comes to the primary outcome like live birth rate and clinical pregnancy rate, but it has shown some reduction in the miscarriage rate, but it does not have any effect on the preterm live birth rate also. So I think this is something which we have a slight another method, but not very useful in terms of improving the reproductive outcomes. Now, in this particular meta-analysis and systematic review, where 5 studies involving 143 patients, they revealed that when it comes to testicular sperms, the DNA fragmentation index is significantly lower in these particular sperms, and also 4 studies in this review which involved 507 cycles and 3,840 oocytes. They concluded in this that testicular ICSI, that is ICSI done with the sperms from testicular biopsy, is associated with a higher clinical pregnancy rate as well as live birth rate, and also associated with a lower miscarriage rate when it was compared with the ejaculated ICSI, means ICSI done with the sperms from source from the ejaculate. Fertilization rate were not so different, but little lower trend in testicular ICSI. It was found by this in this particular systematic review. So ultimately, this looks like with this systematic review, with this number of oocytes and cycles, I think testicular ICSI is probably one of the good strategy when we are handling a higher sperm DNA fragmentation patients. Now, when we see such kind of patient who's got a high levels of sperm DNA fragmentation, in this retrospective analysis, it was compared with 4 strategies. In group 1, there was no absolutely method was altered. It was a conventional way the sperms were selected. Second group received, they utilized IMSI. They were offered IMSI for a selection of sperm. Third group underwent PIXI, and the fourth were again a testicular ICSI. And if you look at it, when these 2 groups were compared, there was no significant difference in the live birth rate. Even when it was PIXI was compared with the control where no technique was used, still the pregnancy rates, though it was slightly higher with PIXI, but they are non-significant. But when the live birth rate was compared, when the sperms were sourced from testicular biopsy, and it was compared with the conventional method, I think there was significant improvement into the live birth rate. And remember, this was a general IVF population, and here elevated DFI was defined as cutoff of 29%. That is more than 29% DFI was considered as a abnormal. And again, it was all patients received a blastocyst transfer. And I think this is something which we have the evidence which tells us probably a good strategy to handle these patients. Coming to now this blastocyst culture and transfer, does it help us for improvement of our optimization of our IVF outcomes? So cumulative live birth rate after fresh and vitrified cleavage stage versus blastocyst embryo transfer in the first treatment cycle. It was this retrospective study in 2016 where 377 patients underwent single embryo transfer on day 3, and group 2 where 623 patients they underwent single embryo transfer on day 5. Now, all these cycles undergone FET cycles were all also included with confidence that survival of frozen embryos were good. Now, when they compared day 3 versus day 5, what they realized that live birth rate was not much difference, but slightly higher in day 5 by around 6 to 7%. Cumulative birth rate was not significantly different between both the groups. The number of embryo transfers necessary until the first live birth rate was significantly lower when it was a blastocyst stage embryo. That was very important finding, that repetition of cycles to get a cumulative live birth rate, probably it required number of cycles was much lesser when it comes to blastocyst transfer. So they concluded that live birth rate per static cycle was significantly higher in blastocyst transfer than a cleavage stage transfer. We go for further analysis of this. Now, this particular study, which I wanted to talk to you about in 2015, where here again it was a cleavage stage embryos were compared with day 5 and day 6 blastocyst embryos, but these day 5, day 6 blastocysts, they were not good quality, they were not top quality embryos, but though they were grade 2 blastocysts. And what they realized that clinical pregnancy rate was more significantly higher into day 5 blastocysts versus day 3. They were high on the higher side, but miscarriage rate was much lower in when it was day 5 non-top quality blastocyst was transferred, and it was more higher when it was day 3 cleavage stage embryo was transferred. So somehow when we go for extended culture and try to select a good blastocyst, it is helping us to select the embryo which will probably help us to reduce the miscarriage, and that can ultimately reduce the clinical outcome. So I do recommend that day 5 or probably day 6 blastocyst will give us a much better results, especially when it comes to optimization. Now, this was another review regarding that's a Cochrane database systematic review in 2016, and it does clearly says that doing a fresh blastocyst transfer is associated with a higher clinical pregnancy rate, and we have a moderate quality evidence for that. But probably when it comes to live birth rate, probably we don't have a very good quality evidence that it really affects the live birth rate. But of course, achieving a clinical pregnancy rate, it does help, and it's definitely something that's a good strategy. Very important second part of our talk is an endometrial factor, how to optimize our results looking at our factor. So as we know that endometrial receptivity is assessed by a variety of parameters, and endometrial thickness is the topmost in the list to look at. So this was a study in 2016 by Valbuena that he demonstrated that if the endometrial thickness is less than 6 millimeter, still we have almost 43% patients having a good receptive endometrium. When the endometrial thickness was between 6 to 12 millimeter, the endometrium receptivity was found in almost 77%, which is the optimal interval of endometrial thickness I feel we are looking at for the reproductive outcome. But also we are always concerned that if the endometrial thickness is more, that is more than 12 millimeter, that goes into a endometrial hyperplasia. We always felt that excess endometrium is not good, but we have a little different experience into the literature where it says that even if the endometrium is more than 12 millimeter, the receptivity in the endometrium has been demonstrated still in 65%. So we don't need to abandon the cycle if we have endometrium like beyond 13-14 millimeter. Another good evidence was the HRT-FET, this particular trial, where in this trial, they tried to find out endometrial thickness threshold. What should be the ideal cutoff of the threshold, and what is the optimal thickness interval? And this was studied in a cleavage embryo hormone replacement freeze thaw embryo transfer cycles. Now here 5,861 cycles they with a cleavage stage embryo, they were divided into 5 groups according to the endometrium thickness. So group 1 had a thickness between 4 to 8 millimeter, group 2 had 8 to 8.9, group 3 had 9 to 9.5, group 4 had 9.6 to 10.9, and group 5 was having 11 to 19 millimeter. Now, what they realized that the clinical pregnancy rate and a live birth rate were much higher in all from group 2 to group 5 patients when it was compared with the group 1. So whenever they found that endometrial thickness below 8 millimeter, there's a significant drop in the clinical pregnancy rate and the live birth rate. They found that cutoff value of the optimal threshold of endometrial thickness was 8.6. That they could see that if the endometrium is having 8.6 millimeter and beyond that, I think the live birth rate chances are much higher. Now, in those patients who had endometrial thickness less than 8.6 millimeter, with each additional 1 millimeter of endometrial thickness, they found out that the clinical pregnancy rate increased by almost 50%, and also live birth rate increased by almost 60%. So uh, beyond 8.6 is something which we are looking at probably whenever we discuss about maximum live birth rate or clinical pregnancy rate. So when the endometrial thickness was thicker than the threshold, that is beyond 8.6, the clinical pregnancy rate and the live birth rate were remained stable. Means even the thickness was beyond 8.6, but even beyond 11 millimeter, almost till 19 millimeter. So that was a very good important evidence that there is not significant decrease in the clinical pregnancy rate or live birth rate, even if the endometrium is beyond 14-15 millimeter. So I think that one particular controversial discussion we can think that we don't need to stop the abandoning the annular at the same time, chronic endometrial thickness, endometrial blood flow also is very important. So identifying the subendometrial blood flow important strategy when it comes to good live birth after the therapy. So this was a study in 127 patients with the presence of good subendometrial blood flow and 38 group B patients with the absence of, and there is a significant decrease in pregnancy rate in group 2 patients. Also in the pregnancy and in group 2 patients who had the absence of subendometrial blood flow. So I think one of the strategy to color doctor when we are doing endometrial scan and find out how significantly blood flow is there. Now, endometrium receptivity is actually involves a subtle collaboration of variety of biomarkers. Now, these biomarkers are maybe stimulated or implemented by embryo, but they result in establishment of some kind of morphological and functional transition of endometrium. Somewhere the endometrium which has developed goes into a favorable endometrium, which allows early fetomaternal interaction and embryo implantation, and important factors which affects endometrial receptivity. So one of the factor is the progesterone elevation on the day of SCG when it is a fresh embryo transfer. Now this was the evidence in 2019. They divided all the patients into 3 groups, that is low responder, intermediate responders, and high responders. Now overall, when progesterone level on the day of SCG was found out to be beyond 2 nanogram per ml, then they found that live birth rate actually significantly declined as you as the progesterone level shown a rise on the day of SCG. Now, when it was compared, the live birth rate was compared in different responder groups, where according to the progesterone levels, the red line is an intermediate responder, the green line is a hyper responder, and the blue line was the poor responder group. So if you look at it, if
Hello. There is some technical issue at the doctor's end. We'll be joining again within a few moments.
Yeah.
Yeah, hello, doctor. You can continue from the previous slide.
Okay. Fine. So I'll go back and I think here from here.
The graph was the progesterone something.
Yeah. So sorry for the interruption. I think there was a
So
break.
just share your screen once.
Okay. Fine. Can you see it?
Yes, I'm able to. Yeah, from this very slide.
Oh,
Yes, you can begin, sir.
yeah. So I'm sorry for the interruption. I think there was a break in the internet. This was a study. We got break here at progesterone elevation on the day of SCG. So in 2019, this particular group they divided all the patients into three groups. That is low responders, then intermediate responders, and a higher responders. So overall, they found out that when the serum progesterone level on the day of SCG was beyond 2 nanogram per ml, then there was significant decrease in the live birth rate. when they studied into a different responder groups. So blue line is a poor responder group, green line is a hyper responders, and red line is a normal responders. So in a normal responders patient, the live birth rate they significantly declined when the progesterone level on the day of SCG they were beyond 2 nanogram per ml. But this was not true with the poor responders. In poor responders, serum progesterone levels on the day of SCG, when it was more than 1 nanogram per ml, there was a significant decrease in the live birth rate. What about hyper responders, which is a green line? Hyper responders did not show that kind of response which happened in normal responders. So, in fact, there was a significant decline in the live birth rate after progesterone levels beyond 2.5 on the day of SCG. So, they concluded that the results of this study they confirmed that the progesterone level had a negative effect on live birth rate in low and intermediate ovarian responders, but not in a high ovarian responders. So they also realized or concluded that for patients with a low ovarian response, the critical value for progesterone elevation should be set as 1 nanogram per ml, while for the intermediate ovarian responders, the critical value should be set for 2 nanogram per ml. Now, also one of the another strategy of measuring the progesterone levels on the day of ET, does it help us to assess the prognosis for ongoing pregnancy rate? So this was a study done on a patients who were undergoing donor oocyte cycle, the oocyte recipient patients. So they measured the serum progesterone levels on the day of embryo transfer, and then they assessed how many percentage of patients were having ongoing pregnancy rate. So depending on these progesterone levels, they divided patients into 4 groups. Group 1 had progesterone levels below 9.2 nanogram per ml. Second group had between 9.2 to 11.7. Group 3 had between 11.8 to 15.7, and group 4 had more than 15.8. Now what they realized that there was a significant difference when it comes to ongoing pregnancy rate, when that was 33% in a group who had a progesterone levels on the day of ET below 9.2, and there was significant higher pregnancy rate, ongoing pregnancy rate, when progesterone levels beyond 9.2. So patients with serum progesterone less than 9.2 had a pregnancy rate of 33%. So that can be considered as a good cutoff, that if we have progesterone levels beyond this cutoff, then we might expect better ongoing pregnancy rate. This was another prospective cohort study who measured serum progesterone levels on the day of transfer. They utilized this as a tool to maximize ongoing pregnancy rate when in the patient who received single euploid frozen blastocyst transfer. Here, the technique was by hormone replacement therapy with estradiol valerate and followed by 100 milligram intramuscular progesterone, and frozen embryo transfer was scheduled 120 hours after the first IM administration of 100 milligram. Progesterone levels were analyzed 1 hour before embryo transfer, and then all the patients were divided into 2 groups. One group, those were 99 patients who were having ongoing pregnancy, and group 2 patient, those included 60 patients who did not have ongoing pregnancy. And they found that progesterone levels on the day of embryo transfer was significantly higher in group 1 who had a ongoing pregnancy, and optimal cutoff value from the group 1, what they found was beyond 20.6 nanogram per ml. So this can be another good evidence to say that to maximize our ongoing pregnancy rate, if we have progesterone levels achieving beyond 20.6 nanogram per ml, then I think that will be a good strategy to optimize our results. Now we know that endometrium receptivity can be affected in following local uterine factors. So one of that is a Mullerian anomalies of uterus. Second is there are some intracavitary lesions like polyps, intracavitary or submucous fibroid or adhesions, or pelvic diseases like endometriosis and hydrosalpinx, and also the ovarian hyperstimulation protocol where excess estrogen production does affect the endometrium receptivity. Now we know that Many those intrauterine lesions can be easily tackled with hysteroscope, and I think doing a hysteroscopy whenever we diagnose some kind of intracavitary lesions like adhesions, polyps, and fibroids, and tackling them with hysteroscopy prior to IVF is one of the very important strategy to improve the endometrium receptivity, and ultimately it improves our live birth rate. Now, hysteroscopy before hysteroscopy before IVF, when it is a normal transvaginal ultrasound of the uterine cavity, should we do a routine hysteroscopy? And this particular study clearly demonstrated that routine hysteroscopy does not improve live birth rate in infertile women with a normal transvaginal ultrasound of the uterine cavity. So if we have a good nicely done transvaginal ultrasound and there is normal uterine cavity, probably doing just a routine even office hysteroscopy may not help us to improve the live birth rate. So this is very important message. Now suppose we have a patient where a patient who has a history of unsuccessful IVF treatment cycle, but still the uterine cavity is normal on transvaginal ultrasound. This study has demonstrated that outpatient hysteroscopy before IVF, it does not improve the live birth rate. So good transvaginal ultrasound along with the help of 3D ultrasound will help you to decide or identify those patients who needs a hysteroscopy, and subjecting these only patients for hysteroscopy probably help us to improve the live birth rate ultimately after the ART. Certain medical conditions, certain pelvic conditions like hydrosulfings should be tackled prior to IVF or no. So there are two techniques, which is one is a prior proximal tubal occlusion and second is a sulfingectomy. They have been proven for the treatment of hydrosulfings were superior when it was compared with no intervention for ongoing pregnancy rate. So whenever we have done proximal tubal occlusion or sulfingectomy for the hydrosulfings, it has always and always shown an improvement into ongoing pregnancy rate. Now, in terms of relative ranking, tubal occlusion was the best surgical treatment, followed by sulfingectomy for ongoing and clinical pregnancy rate. But here, though the dividend says, but I think sulfingectomy is preferred because here we are tackling the pelvic, we are excising the pelvic condition. We are not leaving behind those inflamed pathology. So I think sulfingectomy should be the first choice whenever there is a hydrosulfing, and as and when it should be treated prior to IVF. What about pelvic conditions like endometriosis? Now, recommendations 5 years back has been revised and changed, and it has been seen in this systematic review in 2015 that women with or without endometriosis, they have a comparable ART outcomes in terms of live birth. Only what they have found out that patients who have got a severe endometriosis, that is grade 3 or grade 4 endometriosis, only this group may have slightly reduced or inferior outcomes whenever we discuss about pregnancy rate and live birth rate in this group of patients. But there is insufficient evidence today to recommend that every patient of endometriosis needs surgery before undergoing ART. So we need to individualize. So especially when the ovaries are not approachable or if it is associated with hydrosulfings, I think these are the only two situations where I feel that yes, laparoscopy is must to tackle this endometriosis or to tackle these pathologies prior to IVF. Otherwise, they don't play an important role in improving the live birth rate. Now, yes, as I said, this was a over and hyper response leading to excess estrogen levels in the blood circulation. Does it affect the implantation rate? Does it affect the endometrium receptivity? So this was studied way back in 2007. They said that they demonstrated that whenever the estrogen levels goes beyond 4,000, there is a significant decrease in the implantation and pregnancy rates, and statistically significant difference has been seen when it was compared in this group of patients, especially when in terms of implantation rate. So higher estrogen level is something which we are looking at, that it does not allow embryo to implant. It makes the endometrium unreceptive for the good quality embryo. So that was their conclusion. Now, this was another study, evidence of impaired endometrium receptivity after ovarian stimulation for IVF, randomized trial comparing fresh versus frozen through embryo transfer in a normal responders. So does it make any difference when it comes to normal responders? So in frozen embryo transfer, the clinical pregnancy rate and the implantation rate and ongoing pregnancy rates, they were significantly higher when a frozen embryo, when normal responder patients asked to undergo frozen embryo transfer, when it was compared with a fresh embryo transfer. So the attributed risk percentage of implantation failure due to reduced endometrium receptivity in the fresh group was almost 64.7%. So impaired receptivity is apparently probably accounted for most implantation failures in fresh group, and that is why probably this was the evidence which says. But when a systematic and meta-analysis, what does it has to say when it in 2019 whether all patients should be undergoing frozen embryo transfer, FET for all? That was a question. So this particular systematic review says that there is no difference were observed for live birth rate, especially when in normal responders, when it was compared whether we should do a fresh transfer or a frozen embryo transfer. So there was not much difference in live birth rate when it comes to normal responders. Even it applies for the similar situation for a poor responders also. They did not find any significant difference between ongoing pregnancy rate, clinical pregnancy rate, and implantation rate when these poor responders were offered fresh transfer versus frozen transfer. So again, probably this strategy of frozen embryo transfer is very, very helpful for hyper responders group, and somewhere there in that group, if we put them instead of fresh transfer to frozen embryo transfer, probably we'll have a much better live birth rate in a hyper responders group. We also wanted to study whether FET for all should be a good option or no. So we did this one, our own study, which was a prospective randomized trial. We wanted to see whether better implantation rates with a low estrogen atmosphere in frozen embryo transfer cycle, whether this principle is true or no. So we decided to utilize down-regulated HRT cycle protocol for endometrial preparation during FET cycles for better endometrium receptivity. And our objectives were to compare pregnancy rate between fresh embryo transfer and frozen embryo transfer cycles, and to measure difference in endometrial thickness between initial ovarian stimulation cycle and then subsequent endometrial preparation cycle in frozen transfer, frozen thaw embryo transfer cycle. What's the difference between endometrial thickness? So it was a prospective single-blind control study. All patients undergoing IVF between 2015 to June 2016 were randomly selected. Group A, who had undergone fresh embryo transfer, those were 55 patients. Group 2, who were almost 49 patients who underwent frozen thaw embryo transfer. It was in fresh embryo transfer, they all underwent a protocol, which is a conventional protocol, where we prepared we did an ovarian stimulation with the gonadotropins and antagonist protocol with the SCG trigger, embryo culture till blastocyst stage, so it was a day 5 transfer, and vaginal and oral progesterone was given for a luteal support. In group B, we did a ovarian stimulation cycle first, then we used down-regulated HRT protocol for endometrial preparation in a subsequent frozen embryo transfer cycles. The only one point which is important, that in fresh transfers, we did a oocyte retrieval and progesterone was started from the day of oocyte retrieval. In frozen embryo transfer, we started the progesterone from the first day of progesterone, that is a night dose, and from the second day we gave a 3 times doses, and almost if we calculate from this day, it was the 7th day of progesterone when we did a blastocyst transfer. So patients' characteristics, they were almost similar in our study, but only there are in frozen embryo transfer patients, there were a lot of significant difference between when it comes to how many cycles they were failed previously. So that was around 24 patients had a previous IVF failure, and in fresh we had almost 10 previous IVF failure patients. When it comes to result, we found that positive beta SCG, that is implantation rate per embryo transfer procedure, was significantly better in terms of frozen embryo transfer cycles. Also per embryo transferred, it was also significantly better in frozen embryo transfer cycles. When it comes to clinical pregnancy rate, it was also significantly higher with frozen embryo transfer. But if you look at in a twin gestation, it was almost 20% versus 46%. So that indicates that probably in fresh embryo transferring with transfer of same two number of blastocysts, the pregnancy, especially the twin pregnancy rate 20%, and in the similar other patients group, the pregnancy rate, twin pregnancy rate was higher. So probably we concluded or we found this that in frozen embryo transfer patients, because it was a low estrogen atmosphere, we had a better endometrium receptivity, transferring same number of embryos, that is two blastocysts, but we had more embryos implanting into the frozen embryo transfer cycle, and that concludes that probably we have a better endometrium receptivity in a frozen embryo transfer. And these all patients which we randomized, they were all having different responders. We included all poor hyper normal responders into a similar group. We did not differentiated them into according to the operant response. Also, the second objective was to find endometrial thickness between the first cycle where the ovarian stimulation was done for the embryo vitrification and how much endometrium achieved in the during endometrial preparation cycle. So we found that there was a difference by 1.84 millimeter, and we know that each increase in 1.1 increase in the endometrial thickness by 1 millimeter probably gives us live birth rate of more than 60%. So here we saw that during a second subsequent cycle, same patient will show us by mean higher endometrial thickness by 1.84 millimeter. So our conclusion was frozen embryo transfer cycle gives statistically significant higher implantation rate and higher but not statistically significant clinical pregnancy rates than fresh embryo transfer cycle. For thin endometrium patients during IVF stimulation, better to freeze all embryos and transfer them in a subsequent FET cycle to optimize the results where endometrium is prepared by exogenous prolonged estrogen administration in a down-regulated cycle. So also one of these strategy can help us to improve. So friends, to summarize my talk, whenever it comes to optimization of IVF success rate, a proper case selection is must. Selecting a patient and assessing their prognosis of live birth rate by selecting them below 35 and above 35 as we discussed. Correction of subtle endocrine factors, correction of anatomical abnormalities by endoscopy, most important strategy prior to IVF. Improving oocyte quality by tackling oxidative stress by ultimately giving antioxidants and micronutrients for 2 or 3 months prior to stimulation, and selection of a proper ovulation induction protocol. Improving sperm quality by supplementing them with antioxidants, and use those methods like microfluidic or testicular sperms in terms of for the selection of a source of sperms, especially in patients who has got a higher DNA fragmentation index. Then extended embryo culture till blastocyst to select good quality embryo for the transfer, and frozen embryo transfer than fresh embryo transfer preference due to better endometrium receptivity, especially in hyper responders. I think these are the few important steps when it comes to optimization of IVF success rates. So my dear friends, perfection means not perfect actions in a perfect world, but appropriate actions in an imperfect one, which will make us a perfect clinicians. And yeah, though the world is full of sufferings as we are suffering in this COVID, it's full also of the overcoming it. So I pray to God to overcome all this COVID-19 era, and let's be us as a ART, which is something which is an art to change the life. So I think thank you very much for the patient hearing, and if there are any questions, I am happy to take them and answer them. Yeah. So we had certain questions from our audience. So first question, the second question is by Dr. Jigna from Mumbai. So reason of failure of IVF for a good embryo. Now we need to understand that for us as a clinician, good embryo means assessment of the embryo by means of morphological assessment. But morphological assessment does not give us a surety of the genetic composition of that embryo or the implantation potential of that embryo. So I think many times it does happen that we have say 6 or 7 embryos with us, and we select 2 embryos in the first cycle where the endometrium is good, but still we did not get pregnancy. When we do a repeat second cycle, and from the same cohort, we select no another 2 embryos, and then we get a single live pregnancy. So not each embryo, which is grade 1 morphologically, will give you a live birth rate. So that is something which you can say that is a reason that assessment morphologically, embryo assessment by morphology will not tell you the live birth rate. Next question is by Dr. Amit from Delhi. Max number of IVF that we can repeat in a year. Now, there is no limit as such, but of course, when you do a one ovarian stimulation, the next ovarian stimulation should be at least minimum after 3 cycles, because we know that normal folliculogenesis cycle is of 72 days. So to get a fresh antral follicles, we need to wait for 72 hours. So in a year, if we repeat every 3 months, at least minimum 3 to 4 times we can do it in a year. Next question is by Dr. Deepak from Gurgaon. What percentage of fertilized eggs makes it to day 5? Now that's something which we don't have any evidence, but we have something called as an adequate number of oocytes, which will give you at least minimum 1 or 2 blastocysts by a study by Kolibiansky. So according to that study, if we have a mature M2 oocyte number between 8 to 15, then there is a higher chance that we will have a day 5 1 or 2 blastocysts. But we don't have any evidence that percentage of fertilized will help us to project how many embryos will reach to day 5. Dr. Singhi from Mumbai, her question is recommended duration of cycle before going for second trial. I think I have answered in my previous question. That is minimum 3 months you have to wait for a next stimulation when it comes after first failure. Dr. Mahima wants to know from Ottakamun that can you explain about GNSF bioactivity of the woman who may be poor responder? I'm sorry, is it you mean to say GSF bioactivity? I did not get that. Sorry for that. Then a question by Dr. Jasmine from Mumbai. Can you explain about ovarian reserve in poor responders and how can it help in managing it? Well, Dr. Jasmine, I think X-ray criteria which we all follow all over the world, that is X-ray consensus, that how to assess ovarian reserve. So if we have a patient selected whose age is either 40 or beyond 40, that is one criteria. Second criteria is that if she has undergone previously oocyte retrieval and she has after oocyte retrieval, she had only less than 3 or equal to 3 oocytes after that retrieval, she can be considered as a poor responder. And third criteria, which is a ovarian reserve testing, where the antral follicular count is between 4 to 6 or below 6, and AMH value is between 0.5 to 1.1. So if these ovarian reserve marker test, if they are into this particular so that is the third criteria. So if any patient who is into minimum at least two criteria out of these 3, if it is fulfilling, then it is considered as a poor responder, and it will help you to counsel them about their probable chances of getting embryo, which are going to be lesser if they are elderly especially, and if they're younger, then their chances are better, as well as you can explain them about probably their whatever number of oocytes they will give you, 70 to 80% oocytes will be probably abnormal. So their chances of getting embryo, a good quality blastocyst embryo on day 5 is going to low. And of course, it will help you to decide strategies like giving testosterone transdermal gel before IVF, going for a recombinant FSH followed by recombinant LH in this group of patients, especially when they are elderly, and doing a fresh embryo transfer. All these strategies can help them to get a maximum live birth rate. Dr. Hasina Banu from Butwal, her question is that dose of testosterone and duration of it for poor responder and when to start after conception. It's a very important question. Now, the gel which is available here right now, it has to be applied. It is available as a kind of a bottle where you have something called as one press is called punctuation. So when you start using this particular bottle, initial first 3 punctuation you have to discard. From the fourth punctuation is that is complete one press of the button on the top of it. So one press, whatever dose comes out, that is something of one dose you can calculate, and that has to be administered once in a day. Now, how long we should give it? So at least minimum 70 days we have to give it. So I recommend 3 months prior to IVF. And remember, with the recent evidence, we need to stop from the day of ovarian stimulation. So we should not give testosterone transdermal application during ovarian stimulation or during embryo transfer. We have to stop it as soon as we start ovarian stimulation. Dr. Mamta Chahar from Noida, her question is that any brand for microbiota for how it is to be given. All right. So now there are many brands available. I don't want to mention it any brand names here, but I think those who are supplying lactobacillus species, I think those are preferred. And I think whatever brands we have it in India, they are quite good. But only important thing you need to understand that remember these are spores. Okay, they are lactobacillus spores, and they will be viable if you store them between 2 to 8 degree temperature. Many times the tablets which are just maintained at normal room temperature, they do not give you so good impact. So I think I always recommend that store them in a refrigerator at 2 to 8 degree temperature, and tell even patient to maintain that temperature to have its most efficiency. And they are available in an oral form. Now, there is only one preparation right now in India, which is also available in a vaginal form, where you insert one tablet of that particular brand vaginally once in a day. But I think we have many oral preparations available. So any of these you can be utilized, but room temperature maintenance is really, really important when it comes to lactobacillus. There's a question from Dr. Sudhir from Mumbai. His question is mild stimulation and modified natural cycle is not recommended in POR. At the same time, CC alone or in combination with gonadotropins is recommended. How to account for this? Now, remember, there's a difference between a mild stimulation and modified natural cycle, because in these protocols, you are expecting either one single oocyte. And with CC in combination with gonadotropins, there are chances that you will have at least more than 2 oocytes, that is either in the range in the number of 2 to 4. So it makes a lot of difference when it comes to one oocyte, one mature oocyte, and it is 3 to 4 oocytes. And that is why CC alone in combination with gonadotropins is preferred instead of modified natural cycle, because in those protocols you will have only one oocyte. Remember, that's a big challenge of putting those patients for modified natural cycle. Dr. Sharma Ashish from Amravati, his question is, what is your luteal phase support in poor responders? All right. So my luteal phase support do not change in poor responder, even if it is poor or normal responder, hyper responders. I prefer giving tablet dydrogesterone 10 milligram 3 times a day, along with capsule nitrile micronized progesterone 400 microgram 3 times a day, both together. If it is a fresh embryo transfer, I will start them from the day of oocyte retrieval. And if it is a frozen embryo transfer, I will give it at least minimum 7 days prior to blastocyst day transfer. There's a question by Dr. Hina from Mumbai. Are there increased risk of early menopausal transition and natural menopause after poor response at first IVF treatment? Now, unfortunately, we don't have any studies where poor response at first IVF treatment has given a prediction that early menopausal transition or natural menopause. But in fact, we should be very careful, Dr. Hina, about counseling a patient about natural menopause, because that's something very depressive for them. And of course, it's very difficult to draw a cutoff of years that after so many years, she's going to be menopausal. So I think we should not consider poor response at a first IVF treatment as a predictor factor for this. Next question is by Dr. Purva Sharma from Jaipur. Is there a larger chance of aneuploidy in day 5 embryo stage? You can't say that there is a larger chance of aneuploidy. It is in fact not going to be different. There is no difference of aneuploidy rate in day 5 embryo stage. Remember, in fact, you will understand that those who are aneuploidic, many of them, they in fact do not get converted into blastocysts. So in fact, doing a day 5 blastocyst embryo stage transfer is better for a good selection. Of course, it doesn't completely ruled out aneuploidy, of course, but yes, I think day 5 blastocyst transfer has an advantage when it comes to aneuploidy. Then Dr. Girish from Guntur, his question is, excellent presentation, sir. Do you measure serum progesterone on the day of SCG? And if it is above 2, would you prefer fresh ET or FET? So, Dr. Girish, my practice is that nowadays in hyper responders or any these all hyper responders, we do freeze all cycles. So we do measure progesterone levels, but all hyper responders will undergo frozen embryo transfer. But poor responders and a normal responder group of patients, if the progesterone is above 2 nanogram per ml, I will prefer doing a frozen embryo transfer in this group of patients, as we have already seen the evidence. Dr. Mamta Chahar from Noida, her question is, how do you downregulate in FET cycle? So what I do is here that I give it injectable luprolide, that is 3.75 milligram intramuscular injection on day 21, and I ask patient to wait for 11 to 12 days when she's going to get a withdrawal menses. And once she gets her withdrawal menses, that's a confirmation that she has downregulated. And from the second day, I start supplementing them with a estrogen. Dr. Meena Kharatkar from Nagpur, her question is, in cases which are not micronutrient prime, can they be simultaneously added with ART cycles, and any available stats supporting this management, if any? Now remember, if you start giving her antioxidants or micronutrients during stimulation, probably they will not help us, because the oocytes which are synthesized, which are developed in an atmosphere where you have these micro deficiency, the oxidative stress levels are very, very low in a follicular fluid. And that is why the micronutrients should be given prior rather than during a ovarian stimulation time period. So really speaking, we that is what is the evidence we have. Then there is a question by Dr. Girish from Guntur again, Dr. Anita from Guntur, sorry. Okay. In poor response, fresh ET or pulling off of embryo is better. Yes, I think, is it a question or comment? But I think fresh embryo transfer is definitely preferred. The, frozen embryo transfer, we do not have any evidence that all responders do not undergo frozen embryo transfer, unless until if we have some indications like progesterone beyond 1 on the day of SCG. So all those are poor endometrium, then frozen embryo transfer is fine, but fresh ET should be good. And pulling up of embryos, yes, I will agree with that. That will definitely help. It's a strategy. But if we look at, there is one study where pulling of embryos was done and it was compared with one fresh embryo transfer. There was no cumulative, no pregnancy rate difference between this strategy and a fresh transfer. So if we go by the evidence, I think one fresh embryo transfer is good enough rather than pulling off of embryos. Then Dr. Mayuri from Gautam Budh Nagar, excellent presentation, sir. Thank you, Mayuri. Dr. Ruchita Ramtani from Pimpri Chinchwad, any medicines to improve endometrium thickness before embryo transfer? Great. So if you are doing ovarian stimulation and you come across poor endometrium and your plan is to do a fresh embryo transfer, then yes, I will like to add in this scenario vasodilator drugs, either sildenafil or L-arginine, which are vasodilator drugs. We need to have at least minimum 7 days administration should be done before the day of embryo transfer. And second strategy, which I feel personally, which is a injectable granulocyte colony stimulating factor. We have our own huge data of this particular use of this particular GCSF during ovarian stimulation or during endometrium development, that on an average, if you give this subcutaneously in a dose of 100 microgram dose per day, then it on an average gives you increase in the endometrium thickness by a mean of 1.34 millimeter. So GCSF use, I think something which I will recommend. But suppose if you don't see adequate endometrium that is not beyond 8 millimeter and you feel so, it's better to freeze all the embryos. And during frozen embryo transfer, you have a you can use either you do a hysteroscopy and then correct the problem, or you give little estrogen for a longer time, which will definitely help you to achieve a more and more better endometrium. So those were the questions altogether from the delegates.
Okay, so that's all with the questions, sir. So I'll just request you to give a short takeaway message for the doctors.
Yeah, sure. So, friends, I think thank you very much for the patient hearing. But I think we need to learn those all strategies we discussed. Probably in future, we are going to have more and more strategies which will help us to optimize our results. But I think when it comes to reproductive outcome or IVF outcome, I think look at each and every factor what we discussed, right from the gamete selection of patients, then all those endocrine corrections, endoscopic corrections, and do and follow evidence-based strategies. I think they are something which are really going to make a difference to give you the best of the best results. And I think there are many strategies which comes as a or they introduce to us. Unless until we try them, we do it, we generate our own evidence, and we only ourselves get convinced whether that strategy is good or bad. I think that's something which we need to learn every time whenever from these all webinars. And at the end, I really like to thank Dr. Kedar Gandlar, Secretary ISAR, Dr. Prakash Trivedi, President ISAR, for giving me this platform. I want to thank the Zydus for supporting this academic platform, and of course to DocMod for providing this educational platform. So thank you very much for the patient hearing.